So here is the case study for critical care that myself, Evan, and Ryan are doing. So a little patient history. This patient came in, he's a 62-year-old male. He's 68 inches or 91.3 kilograms. He's a 4-liter nasal cannula baseline, long-standing COPD guy, gold stage 3. He's a 40-pack year history, but he quit 2 years ago. He has hypertension, diabetes type 2, and hyperlipidemia. He had a recent hospitalization for community-acquired pneumonia 2 months ago. So this patient presented to the ED with an increase in shortness of breath, a productive cough that produced green sputum, and wheezing over the past 3 days. So when we threw on an oxygen monitor, he was sitting at 79% with a heart rate of 118 beats per minute, a rate of 32, and his blood pressure was 158 over 92. He was then diagnosed by the emergency doctor with an acute COPD exacerbation with a hypercapnic respiratory failure, likely secondary to a respiratory infection. So the patient was quickly placed on a BiPAP in the emergency department. We set the BiPAP up for Motive ST 16/6 with an FiO2 40%, backup rate of 12, and a targeted rate of 88 to 92. Just because he is a COPD patient, we know that he's normally going to sit around 88 to 92%. We're not looking for higher, we're just looking for stable. At this point, we are going to start just having the discussion of a possible intubation, given the APG results, which will follow later with Ryan, so she'll go into that. The patient was given bronchodilators and ICS in the emergency department to help with breathing. But we just wanted to start the discussion with the doctor and the whole team, let them know that intubation was on the table if we can't get them to start coming back up. So we'll get back to that shortly here.
So first we do a chest x-ray. Chest x-ray shows us they got hyperinflated lungs, flattened diaphragm, increased bronchovascular markings, right lower lobe infiltrate consistent with pneumonia, and then known evidence of pneumothorax or pleural effusion. And so we got that white blood cell count elevated, they're in respiratory distress, and we also have this on the chest x-ray. So that might really tells us that this patient has the case of pneumonia. So the chest x-ray is honestly a really good source to identify pneumonia. But for the purposes of this case study, we went further and did a CT scan to rule out any other respiratory complications that might be causing this. And so areas of consolidation and ground glass opacities were found, also confirming the suspicions of pneumonia as well. We couldn't get a CT scan for this patient, so this patient also has a little bit of COVID, but it's COVID pneumonia in this image. And so since our patient was still hypoxic, had a very bad or pretty poor ABG, we decided to intubate, and we decided to go with these ventilator settings. So tidal volume of 478.8 milliliters, respiratory rate is 16, FiO2 of 100, PEEP of 5. We did the kind of just a starting point, really. So we started at 7 mils, did about at halfway point for respiratory rate, and they were still pretty hypoxic. So we bumped the FiO2 all the way up. We can wean that down if needed, and then PEEP of 5 for a good starting point as well. And so to correct the ABG, we decided to increase their volume, have that minimum inhalation of 5.7 liters per minute to correct the PaCO2, and then 100% FiO2 to correct the PaO2 as well.
All right, so here's a representation of the ventilator graphics and the asynchronies that are present. So I can, as you can see in this photo, this patient's obviously double triggering. So the physician decided we would need more sedation to kind of make the ventilator and the patient more synchronous together. But that does pose a risk of delirium as well. So some of the contributing factors to ICU delirium. So this patient is a 62-year-old, which is an older adult, which leads them to be at a higher risk of ICU delirium. They came in with acute respiratory failure, failed BiPAP, and then they were later on intubated. They were also hypoxic, and their infection risk of pneumonia and systemic inflammation can also contribute to ICU delirium. Also COPD, that's also a pretty big disease that we're all pretty familiar with, which could be another contributing factor to the ICU delirium. And for the CAM-ICU, that confusion assessment tool, so this patient was recently confused and they kind of had deteriorating alertness. They were easily distracted and difficult to focus, which contributes to inattention. Their altered level of consciousness, they were drowsy, agitated, and the result was positive, which indicates that delirium was present in this case, which kind of worries for the increased sedation that the physician decided to do. So some of the things we can do to prevent these ventilator-associated events, so we want to adjust these settings as best as we can to ensure ventilator synchrony. And whenever we can, we do want to do those SBT, SATs when applicable. And that just kind of gets them breathing on their own, as you guys know. And this could also include a sedation vacation as well. Try to take a break from the sedation. And a big thing, which I'll get into more on the next slide, is mobility. Mobility, when applicable, is actually huge. It kind of gets you moving and all that stuff, and that can actually decrease the risk of ICU delirium. And a big thing in the hospital is ventilator-associated pneumonia. So we want to be doing the daily oral cares every 4 hours. I know at St. Luke's we do Q4, and suctioning the subglottic secretions is also pretty big, which is much easier with the high-low in place. And another thing we can do to prevent ventilator-associated pneumonia is keeping their head above 30 degrees, the head of bed. That can actually reduce the risk pretty greatly. And early mobility, like I said last slide, if there's no contraindications, we should totally get these people mobile. It kind of moves those secretions around, promotes lung recruitment, reduces ICU delirium, kind of like what I said. And it reduces the number of days that person's on the ventilator, which is huge. It also reduces hospital-acquired pneumonia, which is also pretty common. And it reduces the likelihood of venous thrombosis and bed sores, which is great. And here's some of our references, but